let me just say that medical thoracoscopy is something which has actually been a game changer as far as diagnosis of undiagnosed pleural effusions is there. And we know for a fact, all of us who have practiced medicine, that when you deal with pleural effusions, many a times you come to a dead end when you find that the pleural fluid aspirate is not giving you the diagnosis. So thoracoscopy involves the insertion of a rigid or a semi-rigid telescopic device into the pleural cavity to inspect and to take biopsies and to perform therapeutic procedures like like pleurodesis. And also you can help to break adhesions. Sometimes in a patient, in some cases you may do a sympathectomy or a pericardial window creation, but that is for the experts. So normally a medical thoracoscopy means that you do it with a single port, while a surgical video-assisted thoracoscopy surgery is done through multiple ports. The procedure, as Dr. Jayaprakash said, it was described years ago by a Swedish internist, mind you, who used a cystoscope to inspect the pleura, and he used it to break adhesions in a patient who had tuberculosis. After that, the procedure, didn't pick up so much, but in the late 80s and 90s, it became very common again, and it was revived by several people. And now it has become a standard practice. And now with the advent of the semi-rigid thoracoscope, more and more, pulmonologists are taking to it. So, what is the basic difference between medical thoracoscopy and the VATS procedure? The medical thoracoscopy can be done by the internist and by pulmonologists. It is done under conscious sedation, unlike the VATS procedure, which has to be done under GA with a double lumen endotracheal tube. Thoracoscopy can be done under conscious sedation in a bronchoscopy suite through a single port, and obviously is less expensive and less morbid for the patient. Now, the usual diagnostic approach when you have a patient with pleural effusion is to do a thoracentesis, look at the color, the turbidity, the smell, etc. of the fluid, and also look at the pH, see if it is bloody, look at see whether it is chylous in look, and whether it has high triglycerides, and also subject it to look at the protein and sugar to find out whether it is a exudate. And you also get the LDH done, and the ADA, the adenosine deaminase, which helps you to decide whether it might be tubercular. The cytology is done on the pleural fluid, which tells you about the presence of abnormal cells and inflammatory cells, and you may also subject this to microbiological analysis. However, with this analysis, you are able to make the diagnosis in about 60 to 80% of the cases. You may tell whether it's an empyema, whether it's a hemothorax, whether it's a transudate because of any systemic illness. Sometimes you are able to tell whether it is TB with the adenosine deaminase is high and you have an exudate. If the cytology is positive, then yes, you can say it's because of malignancy. However, many times you don't have a diagnosis, and then you need to sample the pleura, which means that you need to take a pleural biopsy. Now, this has been traditionally done by a closed pleural biopsy, or lately by a CT-guided or an ultrasound-guided pleural biopsy. But the thoracoscopy has changed that because the yield of thoracoscopy is much higher, as I will show you. So the closed pleural biopsy used to be done with a Copes or a Brab needle. Now we have stopped using these needles altogether since the thoracoscope has come in. Sometimes we do use a fine fine needle or a true cut needle when you have an obvious mass like lesion or a nodule on the CT scan showing a pleural based mass. So there you may use a true cut or a fine needle aspiration from that. Otherwise, the closed pleural biopsies are now not done. You can use it to diagnose TB and malignancy, as I said. If you have CT guidance, the yield goes higher. The advantage of thoracoscopy or blind biopsy, of course, is that you do a complete examination of the pleural cavity and lung surfaces. A biopsy from the parietal pleura can be done under direct vision. And you can, not only do a diagnostic biopsy, but you may also do a therapeutic procedure like a pleurodesis in the same sitting. It allows you to, prepare the pleural surface, optimally for a pleurodesis. And you can also use the thoracoscope to break adhesions and allow the lung to expand. So, these are several advantages of the medical thoracoscopy over the blind pleural biopsy. Now, if you look at the, This is a very large study. This is from the British Thoracic Society guidelines, where they pooled data from about 1,300 plus cases, and they found that the 60% were positive by malignancy by a single diagnostic aspiration. However, in mesothelioma, this positivity fell lower, only about 32%, and a closed pleural biopsy increased the yield by about 7 to 20%. In TB, it diagnosed about 80% of cases. However, when you did a thoracoscopy, they found that in a meta-analysis, the yield of malignancy was as high as 93%, about 90% in mesothelioma, and 100% in TB. So in a country like ours, if you have an undiagnosed pleural effusion, if you are able to offer a thoracoscopy to such a patient, then that is the ideal answer in terms of the yield. If you look at this chart, which is very interesting, because if you have a needle biopsy on one side, a fluid cytology and a thoracoscopy, you find that cytology and needle biopsy together give you the answer in about 75%, but thoracoscopy gives you the answer in almost 96%. And if you combine all these three, you can have the answer in virtually all patients. So basically, what is medical thoracoscopy? What kind of training does it require? Well, the knowledge of pleural and thoracic anatomy is a must. So normally all trained pulmonologists now are expected to be able to do a thoracoscopy. You should be able to interpret radiographic images, and then if you do about 20 such procedures in a supervised setting, then you are ready to go. So it doesn't take long to learn, and it's a procedure which you can maintain competency if you do about 10 procedures a year. Now, what are the indications for medical thoracoscopy? I already said that if you have an indeterminate pleural fluid, if you have an abnormal pleura, if you have a need for pleurodesis, then a thoracoscopy can be done. Also, if you have adhesions, then an experienced thoracoscopist can actually use the thoracoscope to break adhesions. It has been used for taking biopsies from the lung, but we will not get into that. Contraindication, the main contraindication I would think is that if the pleural space is not seen, that means if there's no fluid, or if the pleural space is adherent, that means the pleura and the parietal and the visceral pleura are adherent, then you can't do a thoracoscopy. Of course, you can't do it if there's uncorrected coagulopathy, hemodynamic instability, respiratory failure, etc. So those are the contraindications. The instruments are fairly simple. You have a thoracoscope with a telescope. You insert I will show you the technique. You insert a trocar through a cannula, and then you can use these forceps to take biopsies. And this is an insufflator for doing pleurodesis, and we'll come to that. This is the new device which I was talking about, the semi-rigid thoracoscope, which handles just like a bronchoscope. It is more expensive, but it can be used very effectively to take biopsies under vision. And because it handles like a bronchoscope, pulmonologists find it very simple to use. In fact, you can use the same processor and light source, etc., for using this instrument. So normally, if you have a patient with a chest radiograph like that, a good thing is to do an ultrasound, because an ultrasound will show you where the fluid is, and you can mark an area just above the diaphragm where you can insert your thoracoscope. So normally you make an do an ultrasound examination before the thoracoscopy, and then you try to put the patient in the non-dependent position with the pleural fluid up, so that you find the appropriate position for doing the thoracoscopy. Now let us see. So basically you start off just like a normal. You clean and drape the patient because it's a sterile procedure. You clean and drape the patient. You insert a needle into the pleural space, the marked by the ultrasound, to confirm that there is free fluid there. Then you start just like an intercostal tube. So you'll make a small incision and make sure that you do a blunt dissection to reach the bony cage. And there you will do further blunt dissection with a forceps, and then insert this forceps to go into the pleural cavity. You can see here the forceps being inserted into the pleural cavity there. And once we do that, then we put in some dilators just to sort of dilate the pleural hole that has been created. These are actually the Hagar dilators which are being used here, which are normally used for cervical dilatation. So the surgeon who taught me thoracoscopy showed me how these Hagar dilatation dilators can be used to do this. You can also do this with the forceps. So once this is done, you insert the the trocar for the thoracoscope, and this is the trocar, the thoracoscope in one assembly with the forceps inside and with a telescope. This telescope is attached to the camera. So you can see that trocar has been put in. There was a lot of pleural fluid in this patient, so it is coming out under pressure. The tap is open to the atmosphere. So as the pleural fluid goes out, air rushes in, so that the lung remains collapsed and there is no re-expansion pulmonary edema, even though you may be taking out a large amount of fluid. Once the trocar has been inserted, the cannula is left inside, and then under vision you can actually aspirate the whole fluid. And once you do that, you can see here the diaphragm on one side, the collapsed lung on one side, and you have a brilliant view of the pleura. And you can actually see the pleura under direct vision. You can see this nodule on the diaphragm here and several other nodules on the parietal pleura. So when you have a vision like this, you forget about closed pleural biopsies, because you can take large chunks of these nodules, and no pathologist is going to complain when you take biopsies like this, because you get huge amounts of tissue which can be subject to all kinds of analysis, whichever the pathologist wants to do. So basically, thoracoscopy has completely changed the scenario as far as undiagnosed pleural effusions go. You can see here this whole nodule being taken out in toto by the large forceps. So this is what thoracoscopy offers. Now, now once the thoracoscopy has been done, you can also do a pleurodesis. So once you can see here talc being insufflated. This is asbestos-free talc. There was a discussion just before this as to which is the best agent. This is a good agent to use. Asbestos-free talc is not too expensive. It's about 5,000 rupees. And you can use the thoracoscopic port to spray this talc under vision over the entire parietal pleura and the visceral pleura, so that you will get good apposition once the tube is there and the air is drained out. So you can see here a snowstorm of talc being created and the talc being sprayed all over the pleural surface to give you a complete whiteout of the pleura. Now, once that is done, a tube is left inside. Again, the advantage of the thoracoscopy is that you can put the tube exactly where you want it in the posterior costophrenic angle, and a good drainage can be achieved. And if there are any adhesions, those also can be broken with the thoracoscope. So the risks of medical thoracoscopy: you can have bleeding, subcutaneous emphysema, air leak, infection of pleural space. But mind you, all these are actually very, very uncommon. Now, the agent, as I said, we have already discussed that, so I won't go into it again. Talc is good. Now, some cases for you. So this is a patient who had a recurrent pleural effusion, chest pain and dyspnea for 2 months, and you find that the pleural effusion was negative in cytology. Mind you, sometimes you can have, a pleura completely studded, and yet the pleural cytology you find is negative. Now, this patient had a high LDH, low ADA. You can see the whole pleura completely studded. And when these biopsies were taken, not unsurprisingly, it turned out to be a malignant mesothelioma. So, mesothelioma, we know now that the cytology, for some reason which is not clearly understood, can be actually quite low, and you can have such a patient. Yeah, another patient, 36-year-old, breast carcinoma with a recurrence, pleural effusion refilling after repeated thoracentesis, pleural fluid, a lymphocytic exudate, negative cytology again, which is why the thoracoscopy had to be done to confirm. You find that again the pleura is actually studded with nodules, and once you go inside, you find that the whole pleura is studded with nodules, and not unsurprisingly in this case, it was a metastatic carcinoma, and a talc pleurodesis was done, which was successful. So this is another thoracoscopic picture that I was showing. And sometimes, you have patients like this. If you see very carefully, you can see here these very small nodules. So this patient had pericardial effusion, fever, chest pain, and lymphocytic exudate with a normal ADA. You can see these small nodules. Now, the biopsy, when it was done, it showed caseating granulomas with occasional AFB. Now you can see that how when you have such scattered kind of involvement of the pleura, there is no hope that a closed pleural biopsy or a CT guided pleural biopsy is going to give you that answer. So pleural biopsy with a thoracoscope can give you an answer under direct vision. And of course, this is the garden variety of tuberculosis where the whole pleura is studied, and not unsurprisingly, it showed case-eating granulomas. So with that, I come to the conclusion of my talk that medical thoracoscopy, or what is now called as pleuroscopy also, is a minimally invasive procedure with a superb yield. It has the advantage of being performed under local anesthesia with sedation. It can be used effectively for therapeutic procedures like pleurodesis, breakage of adhesions, and for proper placement of chest tubes. Success of the procedure depends on a proper selection of the case. It is a safe procedure with minimal complications. Training is required, but it is simple and easy to learn and not too difficult to maintain your competency. Thank you very much. Thank you, Ullas, and thank you all the others for giving me this opportunity. And thank you, my chairman, sir, Mr. Jayaprakash, Dr. Jayaprakash, for allowing me this 20 minutes. Thank you very much.